desde donde nos estén viendo. Eh, bueno, agradezco mucho poder estar en este nuestro tercer webinar de esta serie que estamos trabajando en el contexto del Consorcio Internacional de Universidades, con el ICUDR. Mi nombre es Jimena Kalapski, soy la jefa de la Unidad de Reducción de la Demanda de la OEA-CICAD. Me estoy conectando ahora desde España, estoy en el Congreso de la Sociedad Española de Patología Dual, pero no me quería perder la oportunidad de estar con ustedes en este importante webinar, en esta importante sesión. Bueno, hoy día tenemos un invitado de lujo. Muchísimas gracias, doctor Weibord, por darnos esta oportunidad, por estar acá con nosotros. El título de la ponencia del día de hoy del doctor Thomas Weibord es Revisión de la evidencia científica sobre políticas públicas efectivas en adicciones a considerar en América Latina. Voy a leer brevemente algunos aspectos relevantes del currículum del doctor Weibord. Eh, bueno, él es profesor y presidente del Departamento de Medicina Comunitaria y Cuidado de la Salud de la Facultad de Medicina de la Universidad de Connecticut. Él es titular de la Cátedra de Salud Pública y Medicina Comunitaria del Servicio de Salud de Médicos de la universidad y además recibió su doctorado en Psicología Social de la Universidad de Arizona. El doctor Weibord ha pasado muchos años en el campo de la investigación y formación de postdoctorado en psiquiatría social en la Facultad de Medicina de Harvard y cuenta además con una maestría en salud pública en epidemiología en Harvard también. Sus intereses de investigación incluyen la detección, el diagnóstico, la intervención temprana, la evaluación del tratamiento, así como las políticas sobre alcohol y otras drogas. Ha trabajado con la Organización Mundial de la Salud en el desarrollo de la prueba de identificación de trastornos por consumo de alcohol, AUDI, que muchos de ustedes conocen y conocemos, así como la prueba de detección de consumo de alcohol, tabaco y sustancias ASIS, que también usamos mucho en nuestros programas. También es editor jefe de la revista de estudios sobre alcohol y drogas y coautor de los libros Política de Drogas y Bien Público del año 2010 y Alcohol, Ningún Producto Común, Investigación y Políticas Públicas del 2010, que realmente han sido textos de estudio y de análisis para ver cuáles son las mejores estrategias, sobre todo en el área de la prevención ambiental, en la reducción del consumo de alcohol y otras drogas. Ambos libros fueron galardonados con el primer premio en la categoría de salud pública del concurso de libros de la Asociación Médica Británica. Bueno, no me quiero extender mucho más, solamente agradecer como siempre a todo el equipo del Consorcio Internacional de Universidades, de la OEA-CICAD, que nos está apoyando en esta actividad y darle la palabra y saludar y mandar un abrazo y agradecimiento al doctor Thomas Weibord. Muchas gracias. Doctor Weibord tiene la palabra.
Okay. Well, thank you to CCATS for inviting me to do this presentation. And my only regret is that I'm not able to do it in fluent Spanish. But I understand that there's a very good translator available to report what I'm saying. I was asked to talk about the knowledge transfer implications of the scientific evidence on policies for dealing with illicit substance abuse and alcohol problems. And this is a very difficult question to answer, but what I'm going to do is to provide you with a description of how the scientific evidence has developed in the area of drug and alcohol policy. And at the same time, we can cover the issue of implications for capacity building in the area of addiction. And The bad news is that around the world, and in particular in Latin America and the Caribbean, substance abuse, including alcohol and illicit drugs, is prevalent. It's a major public health problem, as well as a criminal justice problem. And it is a problem that has become endemic in that while there are variations and periodically there are epidemics of different types of alcohol and drug abuse, we have not been able to eliminate this problem since it emerged in the late 1960s. The good news is that the scientific evidence has provided us with many options that have a significant public health impact on different aspects of drug and alcohol problems, and that we've built a workforce that is well trained to apply these different approaches. So in the long term, we're going to need to increase that workforce in order to have a stronger public health impact. And I will talk about that at the end. So the next slide introduces the part of this presentation that will deal with drug policy. I'll go on to talk about alcohol policy and cannabis legalization and the opioid epidemic, and then we'll return to this issue of its implications for capacity building to transfer the knowledge into policy and into demand reduction. I will start by summarizing the results of a systematic review of the scientific evidence that was published in 2018 called Drug Policy and the Public Good. And this book has been translated into Spanish by the Pan American Health Organization, and it has also been summarized in an article that can be downloaded from the journal Addiction. And if you put in the title Drug Policy and the Public Good and find the article in Addiction, you'll find a summary of my talk today, at least the part that's dealing with drug policy. In that book, there are over 1,000 research articles and literature reviews and scholarly books and government reports that are summarized at least up to 2018, describing what the scientific evidence is able to tell us about drug policy and drug treatment. Next slide. First of all, the issue of drug policy and drug treatment is quite complex because of the complexity of psychoactive substances in general, which vary in their pharmacological properties, in their cultural symbolism, and in their reinforcing effects, not to mention the addictiveness of different substances. And policies have been directed both at the individual types of substances, but what we're looking for is an overall solution to the extent that alcohol and drug abuse has become endemic in society, and that it often co-occurs in the same people. It would be advantageous to have some general policies that could depress the effects of all substances, particularly polydrug use, at the same time. What we know about the differences among substances is that comparatively, the legal substances like tobacco and alcohol are at least as dangerous as many of the illicit substances. So the current international conventions that separate legal from illegal substances do not necessarily provide a good way of approaching policy because of the ways that these substances affect the population rates of problems connected with addiction. The chemical substance itself in its pure form is just one determinant of the harm. And particularly in the area of drug abuse, harms can be a function of the very illegality of a substance. So you have substances like opioids, which or opiates that can be declared illegal, and that fact in itself creates additional problems connected with criminalization. So policies on substance use need to reflect not only the dangerousness of the pharmacological properties, but also the social context and the types of people who are more vulnerable to develop problems connected with addiction. Next slide. As most of the people in the audience today will know, there are three general approaches on a policy level to deal with the public health problems connected with psychoactive substances and illegal substances in particular: supply control, demand reduction approaches, and harm minimization. And I will go through the scientific evidence on each of these. Next slide. Each of these different approaches has a variety of different options, and supply control, for example, has drug eradication and crop substitution and things like that, which have broad policy goals. And the policy goals from a public health perspective are to increase prices and reduce availability. We also have policies connected with punishment, and increasing penalties for drug possession and use is an attempt to deter drug use and prevent the normalization of drug use by stigmatizing the use of drugs from a legal perspective. This approach has been questioned in some countries, and there have been attempts to correct the stigmatization approach by decreasing penalties. And here the idea, or the broad policy approach or goal, is to prevent the negative effects of criminalizing, particularly the less harmful forms of drug use like cannabis use. And finally, more recently, we've had a lot of interest in the commercial applications of the scientific evidence, particularly on cannabis and opioids, as ways for pharmaceutical companies to bring the therapeutic potential, and this includes psychedelics as well, to bring the therapeutic potential of some of these substances, particularly for pain relief, to the population through the prescription medication system that many countries use to dispense medications. And here, this regulation of the pharmaceutical industry is another approach that can be used. Next slide. An important consideration in supply control measures is the nature of illegal markets. And illegal drugs are commodities, not only in the commercial sector, but also in the illicit market. So drugs are bought and sold, and they're subject to the laws of supply and demand. Many farmers are engaged in growing small amounts of drugs which produce income, and that those drugs are uh, uh, transported to refinement laboratories, and then they are further distributed, transported to the target countries where they're used. Compared to most legal markets, there are many sellers relative to the number of buyers in the drug markets, which means that supply control that focuses on either high-level enforcement of the cartels or street-level enforcement has a lot of difficulties because there are many, many distributors. And even if the market is disrupted by arresting people who are distributing these drugs, they can be replaced very easily. So this is a consequence of the network character of drug distribution, and it relies on and it limits the ability of enforcement authorities to eradicate mass market drugs. So once a drug market has become established, even with massive amounts of interdiction and enforcement and criminalization, it is very difficult to suppress that market because it keeps on coming back. And most market-related harms, like violence and corruptions, stemmed not just from the properties of the drug itself and the behavior of the drug users, but they come from the nature of having a particular commodity become illegal. And when there's a large demand and the drug is illegal, no amount of interdiction and enforcement and punishment is likely to suppress the market. But in general, there are things that can be done to raise the prices, limit availability, and reduce the total amount of drug use on a population level. Next slide. Some of the supply control interventions around enforcement have been investigated in more than one or two countries, but the amount of research in high-level enforcement through criminal investigations and street-level enforcement, as well as even imprisonment, the amount of research is relatively small. So any conclusions that we can draw from the research is limited to the countries where it is conducted, and we don't have enough research to determine whether the theoretical approach of limiting the illicit supply, raising prices, for example, to limit financial availability, is likely to have a major benefit for public health. So the research evidence, even now, is not strong. And that's, I think, an important conclusion that we can draw when we're talking about drug policy. We need better research, particularly in terms of the types of new approaches, policy approaches that have been taken to interdict the supply, to control source country production, and alternative development. Each of these consumes enormous amounts of resources within a country, but we spend most of the money for drug research policy on policies connected with demand reduction, not supply control. Next slide. Prescription drug control strategies are an approach that has been investigated, and we now have pretty good evidence that indicates how prescription regimes, when a drug is legal and is controlled by the pharmaceutical industry, by government authorities, and by the prescriptions through pharmacists and physicians, all of these have been well studied. And we know that changes in the cost or reimbursement of a particular substance, particularly now when it comes to legal use of psychedelics or medical use of cannabis. We know from research on for regulation of pharmaceutical products that changes in the cost of reimbursement can affect how often these drugs are supplied and prescribed, and what effects that has on population rates of drug use and drug consequences. Restrictions on over-the-counter drugs and particularly precursors can be increased by changes in whether the drug is offered by a prescription or sold in a pharmacy where anybody can buy it. Enforcement of prescription guidelines given to physicians can change the prescribing habits, and this was found to be something that is influential in the United States with the opioid prescription epidemic. Prescription registers, getting every prescription registered so it can be monitored and we know where the overprescribed rates are coming from, is another way of controlling availability. And then total withdrawal of a drug from the prescription availability. In some countries now, medical cannabis is prescribed. Opioid pain medications can be prescribed. If we can monitor through a prescription register how often they're used and whether the rates of use or prescriptions are out of the ordinary and very high because of overprescription, we can quickly react to that by either limiting the number of prescriptions or taking the drug off the market entirely. Next slide. Other interventions that control the supply of drugs is trying to find physicians who are overprescribing drugs or patients that are going to the doctors, many doctors for opioid pain medications, special controls on administering opioid substitution medications, although there's been little research in this area, treatment of patients with prescription drug dependence. And here we can see from a large amount of research that it is an effective way of reducing at least prescription drug use of psychopharmaceuticals. And as we've learned, as drugs become commercialized, either psychedelics or cannabis or opioid pain medications, by controlling the market practices of the pharmaceutical industry, we can reduce demand. Next slide. So in summary, supply control interventions can produce temporary market disruptions through high-level enforcement, interdiction, enforcement of street distribution, and other ways of controlling availability. But in general, once drug use has become established and there is a market for profit, either illegal profit or commercial profit, they are the disruptions created by things like policies like interdiction are transient in nature. They don't last very long because the profit motive leads the cartels or the commercial providers to change their practices to keep up with the supply. Local or street level enforcement can be effective, but it generally switches the places where drugs are distributed, and it leads to a new distribution system, which quickly supplies the drugs that have been interrupted. So although supply control interventions can absorb the bulk of control spending in most countries, the evidence for the effect of these is not strong. Next slide. That brings us to demand reduction approaches, which are often considered an alternative, but we now know that they need to be considered in coordination with supply control. And what we have is school prevention programs that attempt to change attitudes and reduce overdose, improve health literacy, and prevent the onset of drug use. We have treatment programs, particularly opioid substitution therapy and psychosocial interventions and self-help groups, which attempt to reduce crime and overdose deaths, and then harm reduction approaches that prevent or attempt to prevent infection and overdose. Next slide. What we know about primary prevention programs is that the more intensive programs and the programs that are directed at family environment and school environment can be effective in preventing the onset of substance use, both alcohol and drugs. So there are a few studies in the US and Europe and in several Latin American countries, particularly Brazil and Mexico, which have shown the potential effectiveness of these more intensive school-based programs. The problem is that working with families, working with teachers, trying to control peer influences can be a labor-intensive type of intervention, which is costly, and the payoff is relatively small. But it is worth including these types of prevention approaches in the overall approach to reducing demand. Next slide. Secondary prevention approaches are based on the idea that if you conduct screening in healthcare and social service settings, and you're able to identify people who use illicit psychoactive substances, cannabis, opioids, stimulants, either detected by self-report screening tests like the World Health Organization alcohol substance involvement screening test, the ASSIST, or through drug screening programs in work settings using breath testing or body fluids, you can identify people who are using drugs. And the screening test can be used as the basis for giving feedback to people, particularly in healthcare settings, about the risks, having a conversation about the difficulties that this could lead to, if not already, and using the results of the screening test just to have a conversation with the patient to motivate them to change their substance use behavior. And what we found from numerous studies, hundreds of studies, in fact, conducted in many countries throughout the world, is that brief interventions that are preceded by the identification of a possible substance use problem through a screening test are capable of providing small reductions in alcohol and drug use. Next slide. Here's a study that was conducted using a screening test that looked at all the substances that people admit to using confidentially in a healthcare setting, giving that information to a healthcare provider, and then delivering a brief intervention. And the brief interventions that were studied consisted of a brief conversation with a healthcare provider and information and referral to treatment if necessary. This study, conducted under the supervision of the World Health Organization, was conducted in Brazil, in the United States, in Australia, and in one or two other countries. And the group that received the brief intervention compared to a control group had significantly greater follow-up after 6 months. And this is consistent with other evidence from other studies. Next slide. For example, a study conducted in 3 cities with 450 chronic cannabis smokers in the United States found that 2 sessions of brief intervention along the lines of a screening test and brief advice about an encouragement to cut back on cannabis use led to significant reductions in cannabis use. And if the same individuals were given up to 9 sessions, there was an even greater change in substance use that was verified by urine screening and follow-up. Next slide. Another area where demand reduction approaches have been investigated extensively is opioid substitution treatment, psychosocial interventions, and harm reduction approaches. And here we have good evidence not only for an effect in getting people into treatment who can use substitution treatment, and by getting people who are in treatment to or to pay attention to more effective ways of preventing infection. We have good evidence that these approaches can be effective in reducing drug-related crime, the spread of HIV infection, and harm minimization approaches are also effective in some countries in getting people into treatment, because when they are develop a relationship in a harm minimization program, many of them can be persuaded through motivational approaches to engage in to register for treatment. Next slide. Another approach that has shown to be effective at a systems level within a country is collaboration between drug treatment and the criminal justice system. So instead of incarcerating drug users, if they are provided with treatment while they are in prison, or if they are started on opioid substitution treatment while they're in prison or soon after they're released, we can see significant reductions in overdose deaths. And drug treatment courts that give people who are arrested for sale of illicit substances or for use of illicit substances, if we provide them with the option of going into treatment, we can see reductions in substance use as well. So collaboration, coordination between the criminal justice system and drug treatment programs is another approach at the level of the system of social services and healthcare, where we can see better uh, uh, reductions in substance use problems than if these two systems are operating independently. Next slide. Examples include the introduction of large-scale opioid substitution services in France and Switzerland, where hundreds of thousands of chronic opioid users were given the option of getting into treatment and the resources were provided. And when France switched to an approach that made opioid substitution treatment available, as well as Switzerland, we saw effects at the population level with reduced crime and reduced overdose deaths. Similarly, evaluations of the drug court system in the United States have provided evidence that there can be better outcomes by channeling more people into treatment. And clinical practice guidelines in the United Kingdom have reduced the amount of pain medications that is prescribed and gotten more people onto opioid substitution treatment. And there's some positive evidence of just reducing the penalties for crime so that fewer people get into prison, but are given a much greater incentive through depenalization approaches to seek treatment. All of these approaches have been shown in different countries to have a positive impact on public health. Next slide. So what are the implications here for drug policy and public health? Well, increasing the number of treatment availability or treatment slots in high prevalence areas is something that can help to control a drug epidemic. Increasing the availability of jobs and job training, including screening for drug use in employment settings. Strengthening communities through the availability of employment and social services is another approach. And finally, drug companies that take advantage of the commercialization of addictive substances, from nicotine to cannabis to pain medications and stimulants, increasing penalties for companies, and in some cases, as we've seen with the tobacco industry, as well as the pharmaceutical industry, when they have been convicted of misusing the prescription of their substances and other approaches that they've used to increase the demand for addictive substances, these companies have been held financially liable, and the money that comes from the court cases can be applied to drug treatment. Next slide. So I'll just say a few words about current options for cannabis control, which is of interest in many countries now. As you know, these range from continued prohibition, including enforcement and penalization of cannabis use. In some countries, the depenalization of or decriminalization, reducing the penalties, or making the use of the substance in small amounts not a crime, have been tested. partial legalization through medical cannabis system in some countries, Uruguay as an example, and commercial legalization where cannabis is treated like alcohol, and finally government monopolies. So we have a variety of different approaches, and research more and more is looking at these different types of policies in different countries. Next slide. The one that's receiving more attention in the United States and possibly in several Latin American countries is making cannabis more like alcohol in terms of its regulation and distribution. And along with this, commercialization and marketing is allowed. So it's treated like a normal business practice to sell cannabis. And commercial producers need to have a license in order to sell these substances, and in order and it allows greater regulation. In general, next slide. Cannabis control using the alcohol regulation approach is being tested, but the initial results are, number one, that at least in some states in the United States, there has not been a dramatic increase in the rates of cannabis use. Nevertheless, more people do seem to become addicted to chronic use of cannabis through the prescription system. And what we've learned is that the political implications, once a drug has been legalized, are that the policies are difficult to reverse. So once a cannabis culture is established, it's difficult to eliminate it. And commercialization has led to abuses through marketing of the product to underage populations and the widespread distribution of cannabis to adolescents. So it has not changed the availability of cannabis. If anything, availability has increased. The good news is that young people in at least some high-income countries and middle-income countries are becoming more health conscious and are using less cannabis as a consequence. But prevalence rates are still very high. Next slide. Another example is the opioid epidemic in the US, which started with endemic opioid use in a number of high population areas, major cities. And in the 1980s, there were a few anecdotal reports that opioids could be prescribed to patients for pain management without their becoming addicted. The research on this was not good, but it was distributed by the pharmaceutical companies, and it turned out to be a terrible mistake to even publish a letter to the editor, because the pharmaceutical companies that developed this new opioid analgesic, oxycodone, then used that poor evidence as a way of justifying the approval of the OxyContin drug, which then led them to a campaign to consider pain as a vital sign. So what we got was the marketing of pain medications in the United States. Next slide. Which used all of the techniques that pharmaceutical companies had developed to get patients to ask their doctors about new drug developments in order to increase the prescription rate of opioid pain medications. And as a consequence, we got dramatic increases in prescriptions over time. And the next slide shows dramatic increases in where opioid overdose deaths were occurring, both at the state level and overall in the United States. So in a sense, we took endemic opioid use in the United States and we created a new epidemic in the general population among older people as well as young people that has been very difficult to reverse. Next slide. I'll skip these slides, which show that how the pharmaceutical industry took advantage of the legalization of opioid pain medications. But the point is that pharmaceutical company methods can be used both to increase demand and reduce demand. And we've seen a clear example of this when the pharmaceutical companies can exact a very high profit from prescribing drugs of abuse, including, I think, in the future, psychedelics. Next slide. You can skip this one. So what do we know about drug policy from a scientific research perspective? Next slide. Demand reduction measures that complement rather than supplement supply control approaches is definitely something that can be used to improve the use of high quality, scientifically supported treatment and harm reduction approaches. So by working more with the criminal justice system, getting more people into treatment and getting them to use the more effective types of psychosocial interventions and opioid substitution medications that are available, we may be able to have a significant effect from a public health approach. Next slide. We need to be aware of the perverse impacts of drug policy, including crime, and we need to take them into account in a cost-benefit analysis, which allow us to consider not only the addictive nature of a substance and how it's controlled, but whether it's stigmatized, whether it, when it's illegal, leads to the spread of infectious diseases and communicable diseases, as well as crime and violence and community disorganization. So the more that the criminal justice system can be used as not a way of punishing people, but by reinforcing the benefits of treatment, early intervention, and harm minimization, the more likely it is that we can reduce drug epidemics and improve the lives of people who become addicted. Next slide. Another lesson that we've learned is that supply control measures have been poorly evaluated, and any changes in drug policy should be accompanied by high amounts of experimentation and funding for research evaluation. Next slide. And we need to be aware of the fact that UNGAS and other international organizations have been very supportive of integrating this balanced approach of combining supply control with demand reduction. Next slide. So the conclusions is that not only do we have some good guidelines for improving coordination within drug enforcement agencies and the criminal justice system and the public health and healthcare system, but we also have learned a lot about how drug policy is formulated. And unfortunately, there is a tendency within political systems to favor less effective approaches because they are more politically feasible. And the practical effect of, for example, improving drug prevention approaches in schools is not as impactful from a public health approach as the approach that uses increased availability of treatment or harm minimization approaches. So here, I think we can switch now to the second part of this presentation, which is alcohol policy. Here, I'll be relying on the evidence presented in a book that was published just last year, which is called Alcohol, No Ordinary Commodity. Paper copies are available from Oxford University Press, and then there's a free electronic version that can be downloaded from Oxford University Press, and a summary article has been published in the journal Addiction. There are translations into Spanish and Portuguese now that are available. Next slide. A number of strategy and interventions have been developed and evaluated, and I'll speak about a few of these. You can arrange them according to their whether or not they are more individually focused, such as demand reduction approaches, or more population-oriented upstream, such as regulating physical availability through supply control and availability regulation, or pricing and taxation, which is also effective in reducing demand. And we've seen some effects of disrupting the system of distribution through interdiction and crop substitution, which leads to higher prices in the area of drug control. So the next slide talks about the best buys. And from a policy maker's perspective, best buys are strategies and interventions that are high in effectiveness, that are supported by numerous studies conducted in multiple countries, and that are capable of reaching their targeted audience. And ideally, we'd like to see these best practices be relatively low in cost. In addition to best practices, the World Health Organization has good practices that are options that have been supported by less research, have a lower impact, but are nevertheless good to implement in a country because they contribute to the reduction in alcohol abuse. Next slide. An example is pricing and taxation policies. In the review conducted of the international alcohol policy literature, in Alcohol, No Ordinary Commodity, we have found that of the 5 approaches that have been systematically evaluated, 4 of them have been found to be effective. The most effective alcohol control strategy is increasing the price of alcohol through taxing the affordability, or increasing the affordability of, taxing alcohol to decrease affordability. Minimum unit prices that prevent the sale of alcohol products at a very low price is another effective approach. And in general, the law of supply and demand is affected by high prices. So the more we increase prices through taxation, the less people will consume alcohol. And that translates, as we've seen, into numerous benefits from a public health perspective. Next slide. Here we see, in the case of Ukraine, a decrease in the real price of alcohol, in this case spirits, between 2000 and 2008, because of increased sales of alcohol that resulted from reduced taxes. And we saw a general increase in the volume of sales. When problems became very apparent, the regulatory system increased the price of liquor by increased taxes, and there was a dramatic reduction in alcohol sales. We've seen from other countries suggested in the next slides, including Russia, the United States, and Ukraine, and Lithuania, that when you have a sharp increase in prices, you can get, as we did in Alaska in the United States, a sharp decrease in alcohol-related morbidity and mortality. But over time, through prices recovering because of inflation, you need to increase taxes relative to inflation. Similarly, motor vehicle accidents are another public health indicator that is responsive to price increases. Next slide. In Lithuania, a 100% increase in beer and wine prices led to a sharp disruption in alcohol-related mortality, plus a sharp increase in revenues that became available through the taxes to the government. Next slide. So what we know from taxation and pricing policy is that taxation is a way to prevent alcohol problems by discouraging heavy drinking. It reduces alcohol-related indicators such as alcohol-related cancers, heart disease, liver disease, and it has the added benefit of providing revenues to the government to fund substance abuse programs. Taxation based on ethanol content is better than taxation based on price. So higher taxes on spirits can channel people into using a lower priced and lower alcohol content beverages, and minimum unit prices that prevent cheap alcohol from flooding the market is another best buy. Next slide. Another upstream approach that has been proven by numerous studies in many countries to be a best buy is limiting the hours and places of sale and the control of the distribution of alcohol and pricing and availability through government monopoly systems, as we've seen in the Scandinavian countries. And these policies that also can limit the density of alcohol outlets by using the license system to prevent the concentration of bars and restaurants and retail outlets that are selling large amounts of cheap alcohol. Next slide. What we've seen in countries like Brazil, where there has been a change in the physical availability of alcohol by changing the hours of sale. In this case, bars and restaurants were closed at 11 o'clock at night in Diadema, Brazil, a city which had one of the highest alcohol-related homicide rates in the world. The time of closure was changed from 4 o'clock in the morning and to 11 o'clock at night. And in 2002, when that change in availability was implemented, there was a dramatic reduction in alcohol-related homicides, as well as accidents, injuries, and domestic violence. Next slide. In Colombia, similarly, restrictions on alcohol availability through the regulation of hours of sale and where people could buy alcohol led to reductions in traffic, in homicides. Next slide. Minimal legal purchase age in the United States led to strong reductions in traffic fatality in young people. When each state was able to decide whether to change the purchase age of alcohol, the states that decreased the purchase age from, or increased the purchase age from age 18 to age 21 saw sharp declines in late night traffic fatalities. Next slide. Next slide. Okay. As I mentioned, monopoly systems are a way of coordinating availability restrictions and price controls and limiting marketing that have been very effective in states and provinces in the USA and Canada, respectively, as well as the Nordic countries. And when these countries have eliminated monopolies or reduced their control of different beverages and allowed supermarkets to take over the distribution of alcohol, we've seen increases in alcohol-related problems. Next slide. Another approach that is becoming of interest in many countries is regulating alcohol marketing. And bans on alcohol marketing as exist in France and now have started to be implemented in countries like Ireland are likely to be an effective strategy by reducing demand for alcohol, because demand can be dramatically increased by the implementation of marketing campaigns by the alcohol industry. So we've seen that promotion of alcohol through television, billboards, print media, point of sale marketing, the social media, product placements in movies, and the huge campaigns that have been conducted through FIFA in the World Cup and now in the Olympics have led to sharp increases in sales where these campaigns are not regulated through marketing bans. So marketing bans are being recommended by the World Health Organization as a best buy. And they're another reason why the legalization of cannabis and other potentially addictive psychoactive substances should be accompanied by marketing bans. Next slide. When companies say that they engage in responsible marketing, they mean that they have avoided even their own self-regulation guidelines. And research shows that marketing reinforces the perceptions of alcohol as positive and glamorous and risk-free. So there is a causal relationship between marketing and the initiation of drinking by young people. And when it's been evaluated in terms of marketing control research, we've found that there can be reductions in the initiation of binge drinking by adolescents. Next slide. This is considered a best buy because it is a regulation that that is at very low cost in comparison to industry regulation, where there is good research now that shows that marketing codes that are implemented and that are controlled by the alcohol industry itself are ineffective. Next slide. So research on the industry's self-regulation codes in the European Union and Africa and Australia show that self-regulation codes are implemented by the industry that says that they're enforcing them. And what we know from industry compliance is that it's actually an excuse for the alcohol industry to avoid regulation. Next slide. Other types of, I'll skip this slide, next slide. Other best practices are drink driving countermeasures that include low blood alcohol concentration levels for young drivers, random breath testing, and intensive supervision programs for people who have been arrested for drinking and driving. These have been found to be relatively effective, but they're expensive to implement. Severe punishment, designated driver programs, safe ride programs, education programs, and victim impact programs have been evaluated, but they've been shown to be ineffective. And these are the very approaches that the alcohol industry favors through their responsible drinking campaigns. And so we can't rely on the alcohol industry to help policymakers select approaches that might be used to deal with alcohol-related problems. They tend to favor the least effective approaches, and often treatment is too expensive to be implemented on a wide scale. And that's why if you want to prevent drinking and driving, it's enforcement of random breath testing and blood alcohol levels. Next slide. In Mexico, enforcement has been found to lead to a decrease in alcohol-related accidents in Mexico City. Next slide. Other approaches that have been tried to control the environment and prevent violence are difficult to implement, but they can be effective. So this includes training bar staff to deal with disruptive bar patrons, and limiting or having practices that limit the number of drinks that are served to people who appeared to be intoxicated. So community mobilization can also be effective in putting pressure on the regulatory system to enforce the oversupply of alcohol to people who drink heavily in retail, on-premise establishments. Next slide. Education and persuasion strategies, as in the case of drug abuse, are labor intensive. They can change attitudes. They do affect knowledge, but the onset, and they can delay the onset of drinking and drinking problems, but the research is not strong, and information-based approaches that just provide information to young people without changing the family environment and limiting the attractiveness of alcohol to young people are not likely to be effective. Certainly, industry-sponsored programs and campaigns have been found to be ineffective. More effective are interventions that focus on high-risk groups, people who are vulnerable because of personality characteristics like sensation-seeking and cognitive disabilities like ADHD, and family interventions are more likely to be effective. Next slide. Treatment and early intervention, as with drug abuse, can be effective, particularly approaches that intervene early in a person's drinking career, because they can get people before they become alcohol dependent. But low treatment coverage in most countries and the high expense of treatment services means that it's unlikely that these types of interventions are going to have an effect at the population level. Therefore, we need a mix of strategies that allow interventions, therapeutic interventions, to be conducted, as in the case of drug control, where the criminal justice system is collaborating to get drunk drivers into treatment, and young people who have vulnerabilities that require their therapeutic interventions to get interventions for alcohol as well. Next slide. So questions that has arisen are, we know that brief interventions can be effective in primary care, but the question is, can we reduce the onset of heavy drinking in young people as well as the general population? And the answer is that secondary prevention is unlikely to have an impact at the population level unless we're conducting campaigns to get people to change their attitudes towards alcohol and to become more aware, next slide, of the relationship between heavy alcohol consumption and the amount of alcohol consumed and the consequences such as the development of chronic diseases like cancer. So treatment policies that make treatment more available can be effective, but they're not likely to be effective at the population level unless there is a dramatic increase in the availability of treatment or the use of harm reduction and therapeutic messages to prevent people from drinking heavily, as has been demonstrated in research on brief intervention. Next slide. So what we've seen is that alcohol use continues to be a major risk factor for alcohol related accidents and injuries. Alcoholic beverage industry is contributing to the growing demand for a wide range of alcohol products, particularly in Latin America and the Caribbean. The expanding economies in these countries make them a prime target for marketing of alcoholic beverages. And the most effective strategies are now going to be strategies that decrease the affordability, that prevent the decrease in affordability through higher taxes and increasing the or decreasing the availability of alcohol through a regulatory system. Next slide. Next slide. So affordable prices, easy availability, a culture of universal drinking, and lack of regulatory controls are what are now the things that contribute to alcohol problems. And effective policies address each of these, and they've demonstrated to be supported by significant scientific evidence. Next slide. The elephant in the room is the alcohol industry itself. And what we need in the next slide is global controls, because in the case of alcohol, as with drugs, the distribution and production of these substances exists on a global level. With the concentration of the alcohol industry, we have much greater ability to control the large corporations, but they are also much more powerful because of their economic power. Next slide. What we need is global governance mechanisms to overcome the obstacles imposed by the alcohol industry. Next slide. Through an international agreement similar to the Framework Convention on Tobacco Control, we need a Framework Convention on Alcohol Control that recommends the implementation of taxation and pricing policies, as we've already discussed, next slide, as well as marketing restrictions, particularly marketing controls on on big alcohol corporations through the digital media. Next slide. I'm just going to say a few words about the implications of national and international policies for capacity building. And the good news is that around the world, there's been a dramatic growth in programs that take the most effective demand reduction approaches and incorporate those approaches into the training programs that are occurring in programs at the university level. So degree programs have become more prevalent, as well as graduate programs and certificates for the training of prevention specialists and therapists. And the goal is to advance research-based practice and policies to improve prevention and treatment. The problem is that while this approach has been effective in training healthcare providers, it has not led to the dissemination of evidence-based policies. Next slide. So the role of public health training needs to change, and we can change it through research being communicated through interdisciplinary training programs that are dedicated to reduction of health disparities. Next slide. The growth of these addiction policy programs should include epidemiology and surveillance and treatment evaluation. We need to increase the availability of research training so that each country can monitor what's going on at a population level in terms of policy. And we need to better study the treatment systems that are now being scaled up in a number of different countries. But training programs need to focus not only on training in therapeutic practices, but also in policy implementation. And the therapeutic providers of therapeutic interventions and prevention programs can be very effective in promoting and advocating for the changes in alcohol and drug policy at a population level that we spoke about today. They can be ambassadors for policy change. And it's not only in treatment, but they need to become advocates for public health policies at a population level. Next slide. So the future demand for training programs and addiction studies is going to increase because of greater investments. But in Latin America and the Caribbean especially, there's a need to expand the workforce, not only in the area of treatment, but also of research, prevention, and policy intervention. Addiction is likely to grow as a specialty area, but if we're going to have an increase of effectiveness of policies at the population level, we need people in medicine, mental health, counseling, social work, and psychology in particular to become much more active in advocating for population level as well as individual level intervention. So with that, I will stop here, and I think we can go for questions and answers if you're interested.
Bueno, doctor, muchísimas gracias. Muy clara la presentación y muy rica. Digo, como para hacer un mini resumen y dar paso a las preguntas, pero creo que ha
Robert,
quedado
solo queremos aplaudir muy fuerte a la doctora.
Perdón.
Perdón, ahora sí, Robert. ¿Sí nos escuchas, Robert?
Ahora sí. ¿Me escuchan?
Sí, perfecto. Le dimos un fuerte aplauso a doctor Weber por esta maravillosa presentación. Gracias, Robert.
Genial, muchas gracias, doctor, muchas gracias, Silvia, por la intervención. Decía, digo, que realmente dio un panorama muy interesante muy integral sobre la temática, abordándola en toda su complejidad, pero siempre haciendo mucho foco en una exhaustiva, en una exhaustiva recopilación de toda evidencia disponible en torno al tema de políticas públicas, ¿no? Hay varias cosas que son bastante alentadoras respecto de, bueno, de que si bien en muchos aspectos todavía falta tener algunos datos, tenemos muchas evidencias disponibles, tenemos guías. Es muy interesante todo el tema del el foco que hizo el doctor respecto del tema del cannabis y de los opioides, ¿no? Son como dos temas de, de alta, este, de alta presencia en diferentes países, en las políticas públicas. Y un punto importante que creo que también mencionó, que es esto respecto de que a veces hay evidencia del funcionamiento de determinados programas, pero a veces desde las decisiones políticas se optan por otros programas, ¿no? Que se adecúan más a los beneficios y a los tiempos de la política. Creo que ese es un punto importantísimo a tener en cuenta a la hora de definir o diseñar políticas públicas y que tiene que ver con los discursos, ¿no? El discurso político y el discurso académico, en donde necesitamos realmente fortalecer mucho esa asociación. Eh, bueno, creo que después fue muy exhaustivo todo el trabajo respecto del tema del alcohol. Eh, Creo que muy importante todo el tema de la evidencia, sobre todo las regulaciones, sobre los impuestos. Este, y me gustó la imagen del elefante en la sala, ¿no? Realmente el tema de la industria y el marketing necesitan ser abordados de manera global. Creo que eso fue realmente algo también que tomamos nota y que es importante tomar nota de todo el tema de diseño de políticas públicas. Y un cierre, creo que un tanto alentador sobre este tema de cómo viene creciendo la demanda de capacitación y la formación de profesionales, especialmente en América Latina, y cómo eso de alguna manera también va a tener impacto o va a tener consecuencias sobre la calidad de las políticas públicas, sobre todo en lo que hace a las evidencias y a las evaluaciones de las políticas públicas. Así que creo que ha sido un panorama realmente muy exhaustivo, muy útil para todos los que estamos trabajando o vinculados a la temática. Y bueno, y agradecer nuevamente al doctor. Estoy viendo a ver en el chat si hay algunas preguntas. No hay preguntas así concretas, pero sí hay algunos reconocimientos, algunos comentarios respecto de cómo se abordan las políticas públicas en algunos países en particular, pero no tenemos ninguna pregunta en especial en el chat. No sé si ahí en el grupo que está Silvia, si hay alguna pregunta específica.
Brevemente, entiendo que el doctor Weber tiene la interpretación para que podamos hablar en español, sino que nos lo haga saber. Pero primero que nada, agradecerle muchísimo al doctor Weber esta visión tan completa, como bien ha señalado mi querido Roberto, la oportunidad que nos da de hacer esta reflexión sobre lo importante que es que en las universidades nos vayamos mucho más trabajando en cómo formar también hacedores de políticas y poder hacer un impacto más fuerte en el campo. De verdad, doctor Weber, muchísimas gracias y tomaremos nota y trataremos de atender entre las universidades que hoy nos acompañan el poder hacer redes más exitosas para establecer esta formación de profesionales y hacedores de políticas públicas. De verdad, muchas gracias, lo admiramos muchísimo y realmente valoramos el que hoy nos haya dado esta gran cátedra de lo que tenemos en el campo. Muchas gracias y felicidades también por esta gran labor.
Bien, sí,
Muchas
yo diría,
gracias.
si tienen alguna pregunta o alguna consulta ahí en el grupo, Silvia.
Perdón, Robert.
Digo, si tienen alguna pregunta o alguna
Sí,
consulta
por
en el grupo.
acá el compañero quiere preguntar.
Hola, buenas tardes. Muchas gracias por la cátedra de hoy. Me pareció como que se tocaron demasiados puntos que yo pues no había considerado para pues todos estos temas, pero uno que me llamó la atención es sobre cómo podemos crear o cómo se puede llegar a una convención internacional para la reducción de daños del uso del alcohol y todo lo que se habló, por ejemplo, para el marketing y esas exposiciones para reducir el daño que genera. Gracias.
Gracias.
Le damos la palabra, doctor.
So, yeah, I think we have had some experience with the drug conventions and whether they've had a beneficial effect. And certainly we've had experience with the International Convention on Tobacco Control. So from those, we could move into a convention on alcohol, which takes the best practices, puts them into a package like the WHO Safer Initiative, where we've got the best practices for taxation and availability controls, a marketing ban, drink driving regulations, and treatment. We put them together, and when a country signs the convention, then they are expected to implement the policies at a national level. The problem has been that, as we've seen with the tobacco industry, when you have such a powerful industry, they can be very effective in limiting implementation at a national level. And we also need to go beyond what was tried in the past few years in the case of marketing, because of the rapid changes in digital technology. So it now is possible for young people on an international level to be targeted because of the profiles that are available through surveillance through the internet, and to target them with messages and images and other types of influence that encourage them to use products that can be harmful to their health. And we've got to control not only the industries that develop those products, but now we've got to deal with the large scale platforms that are operating and the companies that support the digital technologies. That's going to be very difficult, but we need to be much more aggressive in dealing with these industries to change public perceptions in order to make the controls recommended by the World Health Organizations capable of being implemented.
Bien, muchas gracias,
Muchas gracias.
doctor, por la respuesta. A ver si hay una pregunta más ahí en el chat. No, un agradecimiento.
La doctora Medina ahora estaba tratando de entrar al Zoom porque quería felicitar al doctor, darle un fuerte abrazo virtual y hacerle algunas preguntas. Esperemos que pronto pueda tener éxito en ingresar y si no, que nos
Ahí está escribiendo la doctora diciendo,
Ok.
agradeciendo la presentación y que están teniendo muchos problemas con el tema de la naloxona. Así que bueno, agradecemos también el comentario de la doctora.
Well, say
Y-
hello to Dr. Medina Mora for me.
She's hearing you. She's seeing you also.
Bueno, creo que no tenemos más consultas. Así que si es así, damos por cerrado el webinar. Agradecemos muchísimo a todas las personas que estuvieron escuchando, bueno, y fundamentalmente, como decía nuestra querida amiga Silvia, también de esta red de universidades que es ICU DDR. Muchas gracias, doctor. La verdad que nos ha mostrado un panorama súper completo, súper profundo, con muchas referencias y que nos deja muchas pistas para seguir trabajando, seguir investigando y seguir comprometiéndonos, sobre todo desde los campos o ámbitos académicos, con los espacios de políticas públicas, ¿no? Así que muchísimas gracias y los despedimos a todos.
Queremos darle un fuerte aplauso de nuevo.
Bueno, muchas
Keep
gracias.
up the good work.
Thank you very much.
Que tengan un buen día.
Have a
Buen
great
día.
day,
Gracias.
doctor.
Adios.